everybody, welcome back. It is another video in our Caring From and For the Heart series here on Synapse Care Solutions YouTube channel. So my name is Kathy Randall and I'm so happy that you're here with us. This week we have a presentation from Dr. Donna Goff. She's a pediatric cardiologist and she has a special interest in looking at aEEG and outcomes when it comes to babies with congenital heart disease and looking at their aEEG patterns before surgery and even after surgery. So with this presentation, she is looking at what the aEEG patterns are and how do those correlate with long-term outcome. It's really interesting to just look at how far we've come from the 1980s to now in caring for babies with congenital heart disease. It's not enough to do that early detection. What else can we do to optimize their outcomes long-term? We've now really improved their survival, much like premature infants in the NICU. What else can we do to maximize their long-term outcomes? So if you'd like to get the slides to follow along, go ahead and either scan the QR code here on this screen or click the link in the show notes below. You'll be taken to a page where you enter your email address and we'll give you the slides right away. If you haven't already, what are you waiting for? Subscribe to our YouTube channel. It helps us bring you more free content. So if you aren't watching this on our YouTube channel, maybe you're watching it over on our website, go ahead and click the link that takes you to YouTube and definitely subscribe. And if you enjoyed this presentation, hit that like too. It really helps us to be able to spread the word about our videos and offer you more free content. So I hope that you will enjoy this presentation from Dr. Goff and enjoy the conversations that we had and the depth of information about how far we've come in taking care of babies with congenital heart disease. So without further ado, please enjoy this presentation by Dr. Donna Goff.
All right, so Dr. Goff did her pediatric training at UCSF in pediatric cardiology and advanced imaging at Children's Hospital of Philadelphia. And while at CHOP, she also had an NIH training grant focused on cerebral blood flow regulation and risk factors for preoperative brain injury in neonates with complex CHD. During her time as pediatric faculty at Loma Linda University Children's Hospital, she worked with Dr. Andy Hopper and Kathy Randall to develop the neuro-NICU for aEEG monitoring of CCHD neonates in the perioperative period. She is the Fetal Heart Program Director in the Fetal Center at UT Health and Children's Memorial Hermann Hospital in Houston. Thank you so much for being with us, Dr. Goff.
Thank you, Shannon, and thank you, Kathy, for allowing me to participate in this conference. I've already learned so much. I'm excited to be here today and share the work I've been doing and get to talk about it with you afterwards. So I'm presenting some data, just a few slides from our unpublished data, which we're actually actively working on this summer together. And hopefully we'll have more to share in the next 6 months. Over the next 45 minutes, I'm hoping to go over with you the indications for aEEG monitoring in neonates with congenital heart disease. I really want to give you an idea of why it's important to monitor these babies in the pre-op period. We're going to talk about the neurodevelopmental and neurobehavioral problems in babies with complex heart disease, the white matter injury that's seen, and what are the risk factors for neurodevelopmental and neurobehavioral problems in this population. I'm going to show you some studies on pre-op aEEG abnormalities in neonates with CCHD and infants, actually. And then we're going to talk about aEEG abnormalities and predicting neurodevelopmental outcome. So we know that over 50% of survivors of cardiac surgery during infancy are identified with learning disabilities and behavioral issues once they reach school age. And we know these learning disabilities and neurobehavioral problems ultimately limit academic achievements, employability, lifelong earnings, and quality of life. When we talk about the congenital heart disease population, over the last 3 decades, we really have seen improvement in the care, both the preoperative, intraoperative, and postoperative care for these children. And with those improvements, we've really seen decreases in mortality. So as a field, we're really able to now start saying, okay, we know survival has improved significantly. Now we really need to focus on how are these kids doing? What is the morbidities that they're suffering from? Many kids, such as the transpositions, they do quite well. They have one surgery, and overall, from a physical standpoint, a cardiac standpoint, they're doing really great. But the challenges they start to have are with neurodevelopmental issues, with school performance, and the psychosocial issues that come about as they're going through childhood and adolescence and into adulthood. What we know is that many of them can have cognition issues and adaptive function problems. We know that they have speech and language issues and motor problems. And then certainly autism spectrum disorder is seen in a small percentage of our patients, and behavioral problems such as ADHD, anxiety, and depression. Executive function is one of the key areas we're starting to look at in our population. Problems that we can see in executive function are really decreased attention, decreased impulse control and self-regulation, decreased planning, decreased working memory, and decreased flexibility. And we know that these executive function problems are more strongly associated with school readiness than IQ. And problems with executive function can ultimately predict problems with math and reading competence. So when I talk about development, I always look at it as the different developmental time periods and what is affected during those time periods. Many of you working in the NICU or the cardiac have seen the motor delay, the abnormal tone, and the feeding problems that can go along with that, particularly in the patients with hypoplastic left heart. We know as these kids get towards the toddler years, many of those kids can have cognitive delay and have challenges during the preschool years of having issues more from language and speech development. When we get to school age, we know groups such as hypoplastic left heart have lower IQ, but many of the kids will have normal IQs, but they'll have decreased performance. So they'll have problems with executive function, language, fine and visual motor skills. And then as these kids get to adolescent time period, there are problems with increased educational needs and psychosocial maladjustment. And then that carries over into the young adult years and adulthood. So we first started realizing the problems that many of these kids can have from data from the Boston CircRest trial. This was a prospective trial that was done by the docs at Boston Children's, and they studied transposition of the great arteries with intact ventricular septum or VSDs, and they looked at babies that had surgical repair by 3 months of age, and they randomized them into total CircRest versus low flow bypass. And the reason they did that is because back in the late 80s or early 90s, they thought the impact on outcome longer term was due to the strategies utilized during surgery. Now, they looked at this specific population to study because actually transpositions as a whole had at that time good survival rate. And in general, the children with transposition don't usually have genetic or other chromosomal abnormalities. 165 out of 171 patients were alive at 8 years of age. And it was amazing that 155 patients come back to do neurodevelopmental testing and to evaluate outcome at 8 years of age. One of the tests they did is called the Ray Ostery test. And this test evaluates visual, spatial, and executive function. You look at the model on the left, and you need to copy and recall the figure. And it scores for organization, style, accuracy, and overall errors. You can see the picture on the right here. It's a pretty good drawing. It's an 8-year-old with normal neurodevelopment. And that seems reasonable. It looks similar to the model. When they had children that had the transposition babies or patients that were status post switch perform this test, strikingly, there were some kids that basically couldn't replicate it at all and just did pieces of the figure, and many images that didn't really even look similar to the model. And what they realized is that greater than 50% of the kids that they tested, that the copies couldn't even be scored at the basic level because essentially they weren't even at the lowest level of the scoring for this testing. And what they realized is that these kids had poor visual, spatial, motor, and executive functioning. This was really the first basically time point where as a field we're really, these kids have pretty significant deficits even though they seem like they're normal. So as I mentioned, some of the first data came out in the early 2000s on this on the neurodevelopmental outcome. The strategy was called the Boston Circuit Arrest Trial to look at different modalities in surgery and how that impacts neurodevelopmental outcome. What we know is that many kids, everybody was really focused back in the surgical time period because we know that, or suspected that there was injury to the brain during that time period. And of course, the data has shown that postoperatively 50% of babies with congenital heart disease will have white matter injury or PVL, paraventricular malacia, after surgical intervention. But we didn't realize is that even before going to surgery, many of these kids who have been hemodynamically stable without any hemodynamic collapse, many of them will have also findings of white matter injury. And when we started looking at it systematically, we found that 20% of kids before even going to surgery had findings of pre-op white matter injury. And this was important because it really started to tell us that this whole concept that everybody was thinking, oh, it's the surgery that causes the injury. Really, there was a lot more to the story. And really the risk factors for basically the brain injury that we were seeing in this preoperative period was a little bit more complex. And there were multiple factors that were probably influencing seeing this. One being that maybe the way babies regulate their cerebral blood flow is not normal. And I'll show you data in a minute that actually shows that babies or neonates with congenital heart disease have delayed brain maturation. So people were starting to say the story is moving back towards the fetal world where there are changes likely in blood flow that influence how the brain grows during fetal life. So the story kept going back, and now a lot of our focus is in this area of understanding how the fetal brain develops and how that can influence or put the baby at risk for problems in brain injury after birth. This study was done by Dan Lick, neurologist at CHOP. I had worked with him during fellowship. It was one of the first studies that highlighted there is delayed brain maturation in neonates with congenital heart disease. They looked at the brains of normal babies that when they were born at 38 to 43 weeks, and their maturation score on MRI was 12. They then looked at a group of neonates that were at a gestation of 36 to 37 weeks, and their maturation score was 11. And then they looked at the cardiac babies at 37 to 41 weeks at gestation when they were born. These babies actually had a maturation score of 10. This really highlighted if you're born at 39 weeks with complex congenital heart disease, your brain is similar to a 35-weeker. The more immature your brain is, the higher risk you may be for white matter injury during that period. Patrick McClellan also does a lot of work in this area. He's over at UCSF, and this data shows T1 weighted images of the brain of fetuses at 22 weeks, 26 weeks, 30 weeks, and 34 weeks. And here is a term neonate. And what I think you can see here is there is this very smooth pattern here at 22 weeks, that as the fetus matures to the point of where they are term gestation and born, the concavity and convexity of the brain looks pretty complex by the time you get to this time point. Where the hypoplast that's born at 40 weeks, you can see The convexity and concavity is not quite as complex. It seems more similar to a earlier gestation, not quite 34 weeks, maybe a little bit more developed than that, but certainly it does not look like the convexity and concavity does not look like the 40-week normal term on neonate. And so the question becomes, okay, so we know that our babies are at risk for white matter injury and they're at risk for changes in their brain maturation, but does that have any relationship to each other? When we looked at our cohort of hypoplasts, we had 57 hypoplastic left heart babies with hypoplastic left heart that we did pre-op brain MRIs on, and we looked at their brain maturation and the percentage of that had pre-op white matter injury. And what we found is that 19% of this cohort had findings of white matter injury on the brain MRI before even going to surgery. And the lower total brain maturation score was a predictor of this white matter injury. And so this continued to show that certainly the delay in brain maturation can increase your risk for injury even before going to surgery. So then the question becomes so we know from the neonatology world that brain injury during your hospitalization, you're going to be at risk for neurodevelopmental problems. But in our field, we really didn't have any data at the time that really correlated you have PVL or white matter injury, even just on pre-op MRI. Is there a relationship to your outcomes at 1 or 4 years or later? This was one study that was done on transpositions after the arterial switch procedure. They did pre-op brain MRIs to look for brain injury and looked at the 1-year outcomes. And what they found is that one of the predictors of a decreased performance in both the language score and motor score at 1 year of age was having findings of brain injury on the preoperative MRI. So certainly this further helped tell the story of how the delayed maturation and the white matter injury can increase your risk of neurodevelopmental problems. And so for this section, basically what we know is that many of these kids have neurodevelopmental problems, that we know they have white matter injury, and we know that delayed brain maturation can increase this risk of injury. We know that white matter injury, at least some of the early studies showed that there is an association with decreased language and motor performance at 1 year of age. This was really the reason why, as we were starting to talk about monitoring these kids when we started our neuro NICU at Loma Linda to look at the high risk neonates, I really kept asking Dr. Hopper, who was my mentor, to let me monitor our babies with congenital heart disease, because I really wanted to be able to see what data can we find and what can we learn, because knowing that these kids are at risk for injury, are they at higher risk for seizures, and are they at higher risk for other abnormalities on aEEG? I'm just going to give a quick overview of EEG. We know it's a continuous bedside monitoring tool for evaluation of neonatal cerebral function. And we know we can look at the background patterns and sleep-wake cycles and for seizures. The categories that we look at when we are basically looking at the aEEGs and interpreting them, certainly the background patterns and where the continuous normal voltage is considered the normal, discontinuous normal voltage, which in term babies, I should say, are considered mildly abnormal. And then the abnormal findings, which are burst suppression, low voltage, and flat or absent sleep-wake cycles, where we talk about immature or absent, and seizures of absence or present. We know that many NICUs have been utilizing this as a modality to monitor and screen neonates at high risk for brain injury and clinically silent seizures. And we know, as we've discussed, that the neonates with complex congenital heart disease are increased risk for brain injury in the preoperative period. One of the first studies was over in Europe, in the Groningen in the Netherlands. This group is impressive in what they're doing, the different groups that they've studied. And I know they're Dr. DeFries and Dr. Terhars, they're some of the leaders in the field and have done work on aEEG and monitoring. So this group of patients that they looked at had hypoplastic left heart coarctation in transposition. It was 62 patients, and they had gestational ages between 36 and 42 weeks, so late preterm birth to post-term. What was striking about this group, they published this back in 2010, it was probably the early 2000s. Back then, prenatal diagnosis or prenatal detection of congenital heart disease was much lower. It seems similar to the percentages that they had. They only had 15% prenatal detection of these complex defects. And the median day of admission into their units was 3.5 days with a range of 1 to 21 days. When you look over at the bar graph on the right, you can see that in the red is transpositions and in the blue is the hypoplast and coarct. What's striking is that there's certainly a difference between their pH levels, which this being much lower pH and abnormality as a group, but the median lactate levels in these hypoplasts was quite high, consistent with these patients not being detected before birth and coming in with hemodynamic collapse. Now, knowing that they're coming in with hemodynamic collapse is important because certainly this is a group where you're going to expect even more risk for brain injury because of hemodynamic instability. They showed that 45% of the patients had mildly abnormal findings for their background patterns on aEEG, and that 14% had severely abnormal background. And the mildly abnormal background, they actually defined as just discontinuous normal voltage, whereas severely abnormal was burst suppression, flat tracing, or continuous low voltage. They noted that the sleep-wake cycles were present in 36 out of the 62 infants by 72 hours, and that there was seizure activity in 12 of the 62 infants. Almost 20% had seizures. And I'm sure some of that is related to this higher risk for injury with the hemodynamic collapse in many patients. So this same group actually 8 years later published data on and focused really on now the prenatally diagnosed patients. And they had a total of 72 patients that were a variety of many different congenital heart lesions. So hypoplast, transpositions, truncus, tetralogy. And their findings were that in the 72 patients, 26 had mildly abnormal findings on aEEG. 8% or 6 out of the 72 patients had severely abnormal findings on aEEG. The discontinuous normal voltage was mildly abnormal, and the severely abnormal was the burst suppression, flat, or continuous low voltage. This group, 11 out of the 72 neonates had subclinical seizure activity detected by aEEG. 54 out of the 57 neonates with aEEG that was initiated after birth had sleep-wake cycles present by 36 hours of age. And what was interesting is they said 44% of the neonates with an abnormal background pattern was thought to be partially due to sedative use. So as we know, many of the babies will be put on sedatives, and this can influence the aEEG findings. When they looked at their data, they thought that some of the abnormal background could have been influenced by the sedative use. When they looked at the sleep-wake cycles and the time of onset and the background patterns, they noticed that babies with normal aEEG background patterns had time of onset of sleep-wake cycle at 6 hours versus babies that had the abnormal aEEG background patterns developed their time of onset of sleep-wake cycle later at around on an average of 16 hours. And so there was a significant delay in the time of onset of sleep-wake cycle for those babies that had abnormal aEEG background patterns. So We know that the early studies have shown that there's a concern for some abnormality in the background patterns and for seizure activity. And certainly more information from more stable patients that there are some patients that have seizure activity and some have some changes in their sleep wake cycle patterns. Up until that point, there was no data really to link the aEEG findings with imaging modalities or MRI findings, and really trying to look at these cohorts and say, okay, can EEG tell us a little bit more about the risk of abnormalities on brain? Mulkey et al. Out of Arkansas did a study on a cohort of patients that had hypoplastic left heart, coarctation, and transposition of the great arteries. The total of 24 patients. They found that 42% of these patients had a mildly abnormal background, in the same definitions as the previous studies, and 21% had severely abnormal background. And what they found is that 15 out of the 24 patients had abnormal aEEG. And out of those patients, when they looked at their MRI findings, 9 of those 15, or 60% of those patients, had MRI abnormality, including white matter injury, brain atrophy, or even brain infarct. And out of the 15 patients, 5 patients had severely abnormal aEEG and the findings of brain atrophy and absent sleep-wake cycle. And it highlighted that maybe also the sleep-wake cycle can give us more information about the neonatal brain and the cardiac population. We know that mature sleep-wake cycles are present in healthy term newborns and reflect normal brain development. Here you can see an aEEG pattern, that there's quiet sleep and active sleep. So you see a nice pattern that is changing, and that's what you want to see when it's mature. Sleep-wake cycles can be present immediately after birth, but normally emerge within the first 12 hours of a life in healthy term newborns. And we think the presence of mature sleep-wake cycles within 72 hours of birth is predictive of good neurodevelopmental outcomes. And that we know that delayed sleep-wake cycle maturation correlates with abnormal neuroimaging in newborns with hypoxic ischemic encephalopathy. And late onset or lack of mature sleep cycle predicts death or severe disability. And so in one study, aEEG sleep-wake cycles were present in only 50% of the term neonates with CCHD by 24 hours of age. So we know that our neonates with CCHD are at risk for delayed brain maturation and potentially preoperative white matter injury. This may account for changes in the sleep-wake cycles. And this is a T1 weighted image of an MRI looking at a white matter injury here with the arrow. So here are some of our data from our aEEG studies during the preoperative period in our babies with congenital heart disease. And we started monitoring these patients. We really tried to put on the monitoring right after they were born, within the first 8 hours, but really tried to get it on the imaging or the monitoring on as soon as we could. Usually most of the time we were able to get it on the first 6 to 8 hours. The cohort of patients we studied, it's really diverse, or different types of congenital heart disease. We had hypoplastic left heart, which was the largest number of patients, shown coarct, interrupted aortic arch. We had tetralogy, truncus, transposition, and hypoplastic right heart. So it was many different types of congenital heart defect patients. 54% had prenatal diagnosis. A large majority were prostate independent. About 10% needed pressors. And overall, the majority were stable. We had some outliers, but the majority were stable with median pH of 7.3 and a median lactate of 3. There were a few patients that had higher lactate levels, which were associated with some hemodynamic problems. What we found in our study was that 11% of the patients had an abnormal background. only one patient had seizures or clinical activity consistent with seizures. About 1/4 of our patients had immature or no sleep-wake cycle present. The majority of the patients, almost 2/3 of them, really had normal background and no concerning findings. So certainly with our data, we're hoping to now look at some of the outcomes of patients, because I think that's really what's important, is try to look at it and try to compare with the imaging data that we have, but also more importantly, look at the 2-year high risk info follow-up and see how these kids are doing. And we hope to have that data and start looking at that in detail this summer. The one study where they have done a really nice job of trying to look at preoperative and postoperative aEEG monitoring in infants with congenital heart disease is by Littell et al. This is really probably one of the few studies in the literature that are giving information about aEEG findings and prediction longer term of how these kids did. They basically looked at these kids. They were up to 3 months of age when they went to surgery, and they studied both preoperative and postoperative aEEG. And then they followed these neonates at 1 year and 4 years to look at their neurodevelopmental outcomes. And you can see there was a total of 60 patients on preoperative aEEG. Basically, the majority had continuous normal voltage. A small percentage of the patients had a discontinuous normal voltage, which would be considered mildly abnormal by the definitions we talked about. 4 of the 60 patients had findings of electrical rapid seizures, and 55 out of the 60 patients had sleep-wake cycles present. When they looked at postoperative aEEGs and did this monitoring for 48 hours post-op, 4 of the 60 patients had seizures, and 19 of the 60 patients, or 32%, had sleep-like cycles that did not return to normal within 48 hours of post-op. Many of them had a mildly abnormal background of discontinuous normal voltage, and 12% had severely abnormal with continuous low voltage burst suppression and flat tracing. And when they looked at developmental outcomes at 1 and 4 years of age, what they found is that the postoperative aEEG findings of abnormal background pattern and lack of the return of the sleep-wake cycle in 48 hours was significantly associated with a lower 4-year IQ performance. So this was really the first data that's shown us that aEEG can help us identify these neonates or infants with complex CHD who may be at higher risk for neurodevelopmental issues. So summarizing what we've talked about over the course of the presentation today, we know that neurodevelopmental and neurobehavioral impairments affect greater than 50% of children with complex CHD. And we've talked about the different time periods and challenges kids can have during their development with problems feeding early on, cognitive delay, decreased school performance as they get to school age, and certainly challenges in school with increased educational needs and psychosocial maladjustment when you get to adolescent and the young adult years. And we know that these problems are multifactorial. The risk factors for these issues, certainly we know that delayed brain maturation is a risk factor for brain injury, and that aEEG monitoring in both the pre-op and post-op period can help us identify those neonates that are increased risk for white matter injury and neurodevelopmental problems. And I think increasing the awareness, I think, is very important, but really increasing the monitoring and detection of abnormalities and identifying the risk factors that will put these kids at higher risk for neurodevelopmental issues will contribute to improving the quality of life for these kids throughout their childhood, adolescence, and into adulthood. It really does impact them significantly if they go undetected all the way through through middle school and then high school, and then they go off to college and they're really struggling and are having problems with getting through their courses. And if they were detected potentially earlier, may help them be more successful as they go through the educational process. So I wanted to thank a group of people that I'm working with currently to really look at this population in more detail. And certainly all the Loma Linda NICU nurses and NPs and neonatologists that really helped make sure that these patients were monitored and assessed systematically every time a new baby would come in. That Andy Hopper supporting this population, Kathy for teaching me the basics and really giving me the foundation to understand aEEG and its utility in the NICU. And of course, the rest of our team, neurologists, clinical research nurse, and students that continue to help us move forward with this data. Thank you very much. If you have any questions, I'd be happy to answer those.
So I think it always blows me away. I think we heard this the last time you talked, the MRI images of the 40-week brain of a CHD baby and how it really acts like it's a month behind and how it really affects fetal development. And we think so many things, maybe they don't affect what's going on in utero until they come out and we have to do all these transitions, but that's always really fascinating to me. And then using this information that you've gained from your study and the post-op babies, do you increase their follow-up in terms of like if they didn't return to sleep-wake cycling and they do have that risk factor, do you guys do any extra assessments or anything like that other than what they, I mean, I know they're, high risk infant follow-up. Is there anything extra built in? Do they have any additional kind of points where they're, brought in to make sure that they're really thriving or doing okay or have all the services they need?
I think that one of the things I was doing back when I was in California, and I even do it now, but we haven't been getting the monitoring going here, is like all the challenges I think I've heard from other people. We have aEEG and NIRS here at Herman. It's not routinely used on the cardiac kids. We use NIRS, but we don't do the aEEG. And part of it is because I don't think there's many people that can interpret it. In regards to your question, I do try to encourage, and bring up and highlight to the families, how's your baby doing? Are they getting the resources they need? Are they getting the intervention? So that's currently what I'm doing. But when I go back to thinking of back when I was in California and I was doing this work, and I would say, are you getting to high risk infant follow-up clinic? So at 6 months of age, because this was after the CCS, California Children's Services, approved starting to see those patients. I think it was back in 13, 14, right around that time period. And they said, yes, we're going to cover that. So now that we had a resource or that we could refer these patients to, then you could basically say to them, you got to get there, you got to get to the clinic and make sure to be followed, because you're likely going to be at higher risk for these neurodevelopmental problems. So yes, if you have the resource, you can send the patients to that. But I don't think we really have that in our system here compared to like California, where it's a nice system for those kids that have CCS. And that tends to be the most vulnerable population, because for people that are outside of California, CCS is basically Medicaid or Medi-Cal for kids that have chronic disease.
Right. Or high-risk kids that have been in the NICU, have HIE, congenital heart disease, a multitude of things, prematurity. It's a fantastic program.
And so they can get seen by at 6, 12, 24, and up to 3 years, I think. But even then, it's hard because not everybody does it.
Not everybody does it. The follow through is hard, especially if they don't see anything. I think we saw that with some of our follow-up patients. It's hard to, if they're not recognizing anything that's abnormal, especially at 6 months, it's hard to say, come in for another doctor's appointment when they probably have had a lot already or not gotten out of the hospital for that long. And then it's like, oh, return, we need to do this, we need to do that. Hearing more things are wrong with your baby is hard. It's hard baseline, but there's a bit of that if we just got them home. Yeah. And then they have to come back. Jackie's asking if you include these kids in your developmental team rounds.
That is a good question. I'm not sure I can answer it because my perspective was always just from the cardiac area, and I'm not sure how much that really basically got incorporated into the routine NICU care. I think it was more like people like I just went back. I'm an adjunct professor at Loma Linda still, so I'm still working on this, and I have some new faculty that want to continue to work on this. I'm excited because I want to be able to mentor people and keep this going. But I think it fell off a lot once I left. And some of the junior faculty were saying, well, you guys doing it still? And they said, no, they said this was pretty much research. so, it's,
Yes.
I think,
and
yes. And so I think, like I've mentioned, when we were in these chat rooms, you got to have people that really want to, be champions and move this forward in your individual NICUs. You just start small, do something, a small project, and just keep being encouraging and just keep being persistent. And sometimes it'll take on and snowball into more people adopting it and utilizing it.
Absolutely. I think if you ignite their passion, they absolutely will. Natalie was asking if sedation has impact on the lack of sleep-wake cycling. I think you said it did, but just to repeat for her.
Yes, and that's something you have to look at. Some of the studies have looked at that, but some of them have, like I think I mentioned that the background patterns that in that study in the Netherlands, they looked at the sedation medications and that they thought that partially influenced the abnormal background. Well, it certainly influences sleep-wake cycles too. And so it depends on what the sedation is. So you have to look at those details or what kind of medications they're on because it will influence the background patterns and the sleep-wake cycles.
Hey, Shannon, it's Jane. I just wanted to thank Dr. Goff. That was an amazing presentation. As a NICU nurse, it really hit home what a conundrum to be born premature with a congenital heart disease.
Correct.
Oh my goodness.
Yes.
I mean, you're already at a disadvantage for brain development, neurodevelopmental outcomes. And I'm just thinking of the kids that we have that are tiny and that we have to try to grow them before they can have their procedure. It takes us forever to grow them on TPN rather than being grown in utero. The cardiologists are leery about feeding them because they're coarced. So we try to talk them into the NIRS so they can see the gut perfusion and be more confident in feeding the baby. Unfortunately, we have a new cardiologist kind of came from a program that used NIRS. And so he's bringing it over to our NICU. Our NICU is separate from our PICU. So he's kind of introducing that we can be more comfortable feeding these kids and growing them a little bit better. But gosh, that's something. I mean, these are kids maybe we wouldn't normally really focus developmental follow-up on. Of course, they go to early steps, et cetera. But that combined with congenital heart disease really puts you at risk. I'm probably saying something you already know, but definitely your talk made me just really think more about that.
Yeah, thank you, Janie. I think I didn't even highlight that concern, but I can tell you over the last few years that I've been here, it seems like I see a lot of patients that are actually IUGR and preterm deliveries. And I have several hypoplasts, for example, that have been born at 34, 35 weeks. And so I'm thinking they're 35 weeks, their brain's like a 31 week. And it's like, all that chronic care, that chronic intervention, we talk about the toxic stress and all these things that you as a field, the neonatology field are savvy about, right, and know about. But I think about all those things and what that baby has to go through to basically by the time they leave the hospital. And some of them don't leave the hospital for 6 months. So they go through a temporizing procedure, then they have their Norwood and they're not growing and thriving. So then they're not feeding well and can't gain weight because they're IUGR and they're preemie or former preemie, and then they stay till they're Glenn, and then they finally go home. And you think, what is going to be the impact on that baby's?
I mean, that baby's neurodevelopment and the abnormal processing this family has had to do because they've been in the hospital for 6-8 months, whatever it may be. It takes so very long to recover from that trauma. We know that's traumatic for parents.
Right. So it's multiple levels of when you look at the challenges that these babies have to go through. And that's really the extreme cases. The straightforward is you go home after a few weeks, and even those kids are at risk for problems from a neurodevelopmental standpoint.
Oh, sorry. I was going to say, we're only going to discover more as we look into this more.
Your talk couldn't have been more timely and kind of brought the whole workshop together, Dr. Goff, because we had been talking about, I think Lauren Heimel was just talking about trying to get these kids even out of bed, right? Like some of the complicated kids that they have at CHOP, already they're at risk for developmental delays. And then our developmental programs, unfortunately, are not the best, and we don't have staffing and funding for that. So these kids that really, really need that proprioception and the sensory integration of all of that, they don't get it. They're kind of laying in this bed all day with us coming. Sometimes their interaction is our Q3, Q6 vitals, and families have limited interaction for them. So I enjoyed your talk. Thank you.
I think you all can play a role in this. When I go up and see the babies and they're just laying there in the bed, prop them up, depending on what the gestation, their gestation, they're a few months old, figure out how you can give them more stimulation. As providers in the ICUs, you really can play a critical role in small things you do to improve their neurodevelopment.
Yeah, I think it's the tiny touches, right? There's one thing you can do today. If it's reading a book, if it's reading lots of books, talking to them as you go through everything. Thank you so much. I just love your brains and how you're thinking about our tiny babies. It's just fantastic.
Okay, how was that? Was that not an amazing presentation? There was so much interesting information that Donna shared with us on that presentation. She really has a passion for using aEEG to help us predict and guide outcomes, to really understand those patterns of injury that we see, as well as just the long-term outcomes with babies with congenital heart disease. She has a real passion for expanding the evidence as well as awareness around the long-term consequences of babies born with congenital heart disease. Repairing their hearts is just the first step. We need to also maximize all the services and support to maximize their long-term outcome. So I really hope that you enjoyed this presentation. If you'd like to get the slides, go ahead and scan the QR code here on the screen or click the link in the show notes below. You'll be taken to a page where you enter your email address and we'll send you the slides from this and all the presentations in this month's series on caring for and from the heart. So if you've missed any of the other videos, the link should be in the show notes as well, or just check out our homepage on our YouTube channel. So if you haven't already, what are you waiting for? Subscribe to our YouTube channel. It helps us bring you more free content. And if you enjoyed this presentation, hit that like too. It really helps us to be able to spread the word about our videos and offer you more free content. I hope you've been enjoying this series on caring for and from the heart, and we'll see you next time. Bye.